This is the second section of our HBT ultrasound training module entitled Sonographic Anatomy of the Gallbladder and Bile Ducts. In this section, we are going to correlate normal biliary tract anatomy with how these structures appear on ultrasound. A lot of the biliary system can be evaluated with sonography. The gallbladder and extrahepatic bile ducts are easily seen in transabdominal ultrasound. The intrahepatic ducts are, however, usually too small to be seen if they are not dilated. To see the gallbladder and bile ducts, the parasagittal plane view is often a good way to start. One needs to slide the transducer across the upper abdomen in a parasagittal plane. The bile ducts and surrounding anatomy, such as the liver, the IBC, the aorta, portal vein, gallbladder, can be seen easily along their long axis. The gallbladder is usually seen in its long axis as an anechoic pear-shaped structure that is positioned superficial to the right kidney. It is lateral to the head of the pancreas and the duodenum. Normally, the gallbladder has a cystic sonographic appearance with echogenic walls and an anechoic lumen. The fundus, the body, the neck of the gallbladder can be clearly seen in these ultrasound images. The actual cystic duct, where it drains into the CBD, is often very hard to discern on ultrasound. The gallbladder wall usually appears echogenic and thin, normally around 2 to 3 millimeters. Note that the gallbladder wall in contact with the liver bed appears to be thinner, and the gallbladder walls in contact with the duodenum and other viscera appear thick. This is due to acoustic enhancement from the fluid-filled gallbladder lumen. In addition, the duodenal wall, which is in contact with the gallbladder, can make clear discernment of the gallbladder wall difficult. Hence, in a lot of patients, the wall of the gallbladder in contact with the liver bed is used for wall measurement, the anterior wall right here. Main lobar fissure. The main lobar fissure runs obliquely between the neck of the gallbladder and the right portal vein. It separates the functional right and left hepatic lobes. In sonography, the main lobar fissure is an important anatomic landmark. It is an echogenic structure between the portal vein and the gallbladder neck. It can be used to identify the gallbladder and differentiate it from other anechoic structures like the hepatic vein, portal vein, and the inferior vena cava. Gallbladder configuration and structure is very dynamic. There is a wide variance in shape and orientation, and in a good number of cases, internal septation may also be evident. There are some common variations in gallbladder shape and structure that may be evident on ultrasound. One is the pharyngeal cap. This is seen if the fundus folds on itself, like what's shown in this diagram and in this ultrasound image. The Hartmann's pouch might also be very pronounced in some patients, but in some patients it's not even seen. Differentiating the gallbladder from other structures is key in its identification. The duodenum, or other intestinal loops, is a frequent area of confusion, as they have similar appearances on ultrasound. The primary method to tell the two apart is to examine the appearance of their respective walls. Intestinal walls appear hypoechoic and contain an echogenic lumen, in contrast to the gallbladder, which has echogenic walls and an anechoic lumen. The luminal characteristics may be similar in certain pathologic conditions, but the wall characteristics are usually preserved. Another point of difference is peristalsis. Peristalsis can't be seen, of course, in the gallbladder, but in the intestine, if you observe long enough, this might be visible. When scanning on the transverse plane, the gallbladder, the aorta, and the IBC can have very similar appearances and can be confused with one another, as one can see from this ultrasound image. All have anechoic lumens, and all three have echogenic walls. To distinguish them, their position relative to one another is their primary difference, as the gallbladder would be found anterior to both structures, and the IBC would be found close posteriorly to the gallbladder, and of course the aorta would be seen most medially. If doubt still exists, one may use Doppler mode imaging, since the gallbladder would not demonstrate any luminal flow, no, and the other two structures would. Evaluation of the biliary ducts is a bit more tricky than gallbladder evaluation. The first step in evaluating the biliary system would, of course, be how to locate the common hepatic and the common bile duct. Extrahepatic bile duct walls are brightly echogenic. And if one would review normal anatomy, these ducts could be seen anterior to the portal vein and mostly lateral to the common hepatic artery. The portal vein is easily located and is thus used as a landmark for locating the common bile duct. Bile ducts, portal vein, and hepatic arteries all have echogenic walls and are thus subject to confusion. Doppler mode imaging may be of help in these cases, as vessels would reveal flow and the bile duct would not. After identification of the common bile duct, its diameter could be measured from its inner walls. In the Filipino patient, less than 60 years old, normally it's less than 6 millimeters and may be greater for older patients. In post-cholecystectomy patients, there is normal enlargement of the common bile duct, and you could sometimes see bile ducts up to 1 centimeter in diameter. A diameter larger than these measurements should lead one to suspect distal obstruction. The anatomic relations among the portal vein, hepatic artery, and common bile duct are key to accurately localize and identify these structures, as these structures have similar sonographic characteristics, echogenic walls with an anechoic lumen. As can be seen when viewing these structures on a short axis on the left, the common bile duct can be seen anterior to the portal vein and lateral to the hepatic artery. This is commonly referred to as the Mickey Mouse sign. When viewing these on the long axis, the relationship remains the same. The common bile duct is seen anterior to the portal vein, running parallel along its course. We usually use this long axis plane in locating and measuring the common bile duct. The inferior vena cava is also seen here in this view below the portal vein. In evaluation of intrahepatic bile ducts, There are a couple of key points I would like to emphasize. Normal-sized intrahepatic ducts cannot be seen on ultrasound, and they must be differentiated from hepatic veins and portal veins within the parenchyma. If there is no biliary obstruction and no biliary ductal dilatation, one would not expect to see the intrahepatic ducts on ultrasound. When there is apparent biliary ductal dilatation, it is important to distinguish these from hepatic veins and portal veins. The hepatic veins are easily and clearly differentiated from the intrahepatic ducts by their course and by their walls. The walls of the hepatic veins are not echogenic compared to the bile duct and portal venous system. If one would follow the hepatic veins on the transverse axis, they would be seen draining into the IVC. Distinguishing dilated bile ducts from the portal venous system is a little bit more tricky. Here are some examples of dilated intrahepatic ducts. Now, both portal veins and IHDs have echogenic walls, and they run side by side each other. But for the purpose of being able to determine the presence of intrahepatic ductal dilatation, if one sees echogenic tubular structures running side by side one another in the liver, this should alert you to the presence of dilated intrahepatic ducts. And this is known as the parallel channel sign. The presence of the parallel channel sign is suspicious for dilated intrahepatic ducts. If doubt exists, Doppler mode imaging may again be of help, as flow will not be demonstrated in the bile ducts. This ends the section on sonographic anatomy.